All right, so our goal is to try and determine from a 12-lead tracing where exactly the ischemia, infarcted area, whatever is, especially if we can get it during the ischemic or injury stages. There are those things that I can do to try and resolve the occlusion and hopefully reperfuse that muscle and not lose it. Each of the areas makes a difference because the manifestations you're going to find are going to be different. An anterior MI, anterior wall MI, presents totally different than an inferior wall MI, both clinically and how they respond to therapy. So it's very important to be able to determine this. Again, it goes back to the coronary arteries. So you'll need to have that concept of which arteries feed which wall in which area of the heart. We can have either a transmural, meaning it's going all the way through, in which case a Q wave will appear, or you can actually have a subendocardial where it's only the endocardium that is being involved. It's not the myocardium to a large extent. And in that case, we're going to call that a non-Q wave. We really look at it, the presence of ST elevation and those that don't have ST elevation. This is part of the problem, and you probably have heard of situations where somebody came to the doctor's office or to the ER with chest pain, and they sent them home and they died from a heart attack on the way home. Well, it's not a perfect science, and that's why now what you end up seeing is if somebody comes in complaining of chest pain, one of the things that you need, and they have some suspicion as far as the markers involved, their troponin might be increased, their CPK-MB might be increased, they'll keep them and they'll watch them. Because those are the ones in that second group, that non-ST elevation, where you end up having ST depression instead, and those markers present, and these people are at increased risk because they're not as easy to define where the injury is at. So again, we're talking about a Q wave. We're talking about a Q wave that is at least one small box in duration, and also we want it to be at least a third of the height, the distance. That's what I'm going to use here. The height of the Q wave, how deep it goes down, should be at least a third of the subsequent R wave after it. Okay. So the ST elevation that we'll see, the higher the ST elevation, the larger the amount of muscle mass that is being involved, and the more significant the occlusion is. So you should know how an 12 lead is laid out. I think I give you one easy question where I ask you which lead is located here. I don't have the V2 there, but duh, you should be able to tell me it's V2. Okay, so it's 1, 2, 3, your 3 limb leads, followed by your 3 augmented voltage leads, followed by your 6 precordial leads. Usually on the bottom, they'll end up having a rhythm strip with usually at least lead 2, if not some of the other leads involved also. Okay, so that's what those 3 on the bottom are just a continuous EKG, where these on top are simultaneously looking at the 12 leads that are there, each individually, but this beat that is measured here in lead 1 is exactly the same in lead 2, exactly the same in lead 3, etc. Okay, so it's all looking at the same heartbeat that is there, but you're looking at a shorter duration of it. So again, this is our limb leads and our precordial leads. This is out of your text. And that progression of our acute coronary syndrome going from ischemia through injury through infarction, you're going to see that changing happening. We talked about the T wave getting larger, and the T wave, the ST segment elevation looking like a chair and a seat or a fireman's hat. It's been described a couple different ways, and I'll show you what I'm talking about. We're looking at that. Talking about a Q wave development when the infarction happens. And there's something called poor R wave progression, and I'll show you what that looks like. But looking at the V1 through V6, the R wave, the positive the deflection that you end up seeing gets larger as you go across the precordium. Okay. So here's our evolving MI. In the acute phase, you just have a tall T wave, and usually we don't even see that. Early acute, you end up having ST elevation. Can everybody see where the ST elevation is there?
Yeah.
Okay. You can see how it kind of looks like a chair. Okay. The seat is elevated. In fact, the seat can be elevated so extremely that it just becomes right. And then you have a T wave inversion as it gets later in the process. Development of a Q wave, and that Q wave never goes away. So that's how we can tell that there was a prior anterior MI at one point in time, even though now it's fully resolved. There's no more acute process going on. You can see it there. So T wave elevation, ST elevation. ST elevation remains with the T wave becoming flipped, and then the development of the Q wave. So going from an ischemic through an injury through to infarction. Got it? Sure, why not, Rick? When we talk about R wave progression, as I mentioned, the first positive deflection of the QRS complex is the R wave. And you can see here in V1 it's very small, V2 it gets bigger, V3 it gets bigger, 4 bigger, 5 bigger, 6 bigger. Okay? That's the normal. When you have damage to the heart, you're not going to see that R wave progressing normally. And it's just basically looking at, again, R wave is measuring a positive deflection, is moving in the direction that that impulse is moving. Let me rephrase that again, because I'm sure it didn't make any sense. Where's the negative electrode in V6? It's in the center of the chest, and it's looking this way. V5 looking this way, V4, V3, you get the idea. So as you're looking here, V1, the R wave is very small with a very high S wave because the way it's looking is opposite of the way the current is moving. Most of the electrical activity is moving towards the left ventricle because it's a bigger muscle mass. So this lead is looking in the opposite direction. That's why the R is very small. As it progresses and goes more in a normal direction, more towards the left side of the heart, the R wave gets bigger and bigger and bigger. If it doesn't progress, it's probably because the muscle mass it's supposed to be looking at is damaged. And as we'll see, poor R wave progression occurs when you have a big either anterior or a lateral wall MI. And here's an example of it. No R wave in V1, none in V2, very small. Here's my R wave. V4, still very small. V5, the hell is that? V6. So you don't see that nice progression that you would end up seeing. It's telling me that there's some damage to the tissue itself because it's looking in the direction that the lead is measuring. Does everybody understand what I'm saying when I'm saying that?
So the V5,
V5 is looking.
that's the bad part of the heart then?
No, it's a lateral wall. Where's V5 placed? Yeah. V6 is true mid-axillary, V5 is anterior axillary, right? So that portion is basically the mass of the left ventricle. If I don't see a real big R wave there, that means that there's no impulse going in that direction because it's dead. Okay? Okay. So let's talk about the coronary arteries and ECGs. 2, 3, and AVF are primarily looking at the right coronary artery. The left coronary artery has everything else. Because the left coronary artery, remember, branches into two. The left circumflex, which wraps around, covers the left side of the heart and continues on to the back. And the left anterior descending, which covers the entire anterior wall of the MI. Very nice picture. Very good thing to study from.
Where's it at, though?
It's probably not 239 because that's the old text. Can I see your book for a second? This is right. I think she took this from the Heart Association. You know, maybe she doesn't have it in a new. It doesn't look like it's in a new edition, but she has each of them broken out. And should be in chapter 9 someplace, but I don't see it. All right, well, let's talk about how this is arranged. Now, notice what the author did here is they took the ECG picture, the tracing that you have, and broke it out color-wise as to which areas are going to have for each parts of the heart. So, if you remember, this is a box. We're talking typically about the left ventricle, not the right ventricle, the left ventricle. And that left ventricular wall has an anterior side, has an inferior side, has a lateral side, has a septal side, and has a posterior side. Bless you. Leads 2, leads 3, and leads AVF are associated with the bottom of the heart. They're all looking down. 2, 3, AVF. They're all looking towards the bottom of the heart. So the inferior wall, any changes to the blood perfusion of the inferior wall will manifest itself with changes ST elevation, ST depression, ST elevation, T wave inversion, blah, 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 in 2, 3, and AVF. Okay. And that typically is supplied by the right coronary artery. Some extent the left anterior descending, but for the most part, the left circumflex, for the most part, it's the right coronary artery. Leads 1, where does 1 look? Katie, where does 1 look? This way. Right shoulder to left shoulder. So it's looking to the left. AVL, where does AVL look? Center of the chest, left shoulder. V5, V6. Coming out on the left side of the lateral wall. So lead 1, lead AVL, lead 5 and 6 are looking at this lateral wall, which is typically fed by the left circumflex. V1, V2 are looking at, coming across the sternum, they're looking at the septal wall. V3, V4 is looking at my anterior wall. Very, very important. Brian.
Can you think like a visualization for lateral circulation?
Sure. I should have grabbed that heart model that's next door. What's that?
It'll make more sense, like, yeah, if you just do your little red little thing, your little squiggly there.
For what?
Just showing lateral circulation, you know, with older people as opposed to young people.
With older people, as their anterior wall as plaque starts developing, they start developing alternative arteries that come and bypass around. So, again, the young person who has an ischemic incident is going to be more problematic because they don't have that other circulation developed yet. Okay, let's take each of these individually. So here I have a look at 6 different leads of my 12 lead. And what I want to identify is there any area here that has ST elevation and T wave inversion, which is what you would see as that involving process going from ischemia through injury and not quite yet developed a significant Q wave. So this is still a heart that's viable. Where is the location of the ischemia and which artery is associated with it? Does lead 1 have ST elevation? Has ST depression, doesn't it? Okay, keep that in mind. Lead 2, ST elevation? Definitely. Everybody see it there? I can't get this thing to work. Yeah. Here's my isoelectric line. You can see that the ST is definitely higher than that. 3? Yes. So lead 2, lead 3. Well, who should I immediately go to, because I know it's going to be there, is AVF. And indeed it does. The other leads have either no ST elevation, minimal ST elevation, or depression, or true depression with an inverted T, which are the reciprocal changes that we're going to talk about. For right now, just looking at the primary, 2, 3, and AVF tells me where? And which artery? Right coronary. So if they're going for a cath, they would go and they would scope out the left, but also scope out the right, because they think that that's where the site of the area be. Now, what else does the right coronary artery feed? Beside the right ventricle, close. The conduction. Yeah. Yeah, so a couple of things that you'll see with an inferior wall MI. One is you are prone to having problems with conduction disturbances. So an inferior MI is often associated with heart blocks. Second degree, third degree heart block that we'll get to. They're also associated with right ventricular MIs because the right coronary artery feeds the right ventricle. Okay. Interestingly, think about how the heart is positioned within the person's chest. The inferior wall sits where? Right onto the diaphragm. What's below the diaphragm? The stomach. That pain that is occurring is transferred often to the stomach. Inferior wall MIs often are associated with nausea and vomiting and heartburn. Okay? Okay, so it's an inferior wall, yes.
So inferior wall, the right coronary artery, also feeds the conduction?
The AV node. If you remember, part of it's fed by the circumflex and part of it's fed by the right coronary artery. First lecture.
Yeah.
And again, we talked about those reciprocal changes, which is what you're seeing with some of this ST depression, especially in AVL.
Reciprocal changes, is that just looking at
Well, if I have damage down here, anything that's looking up here is going to give me the opposite picture.
Okay, the opposite.
And that's why the AVL has such a significant ST depression. Yes.
So if you're they would still be able to have
You're at risk for having problems with things like second degree, type 2, third degree heart block, because the AV node may be damaged. Because that same vessel that's feeding that part of the heart, if it's high enough, if you think about it, it branches here, it branches there, it continues on down to the inferior end. The blockage may be way down there. But if it's higher up, now we got more of a problem.
Pacemaker might be.
That's where a pacemaker might be necessary to be able to control it, correct. And we'll talk more and more about that when we get to the individual rhythms themselves. Okay, lateral, think left. Lead 1 looks left. AVL looks left. V5 and V6 are looking at the left precordial surface. These are survived by the left circumflex, which is a branch of the left coronary artery. There often is an extension into both the anterior and inferior wall. So you can have an inferolateral or an anterolateral. Oh, God. So it's not often just a pure lateral wall MI, although it can be. Okay. And again, because the circumflex feeds the AV node, again, same kind of picture can happen with AV blocks. And here's our left circumflex. Here's my left coronary artery, branches into the anterior descending with all of its multiple branches. And this is the one that wraps around the corner. This is what's going to end up feeding it. So 1, L, 5, and 6, lateral wall. And if we look, we can see some changes. AVL. Not so much in 1, but certainly in AVL, and certainly in 5 and 6. Definitely 6. And because I see some changes in 2, 3, and F, I'm guessing this is probably an inferolateral. Some inferior wall also there. I will tell you on your final, I will be nice and just have 1. It's bad enough as it is. Inferior, we talked about pointing down. 2, 3, and AVF is where you're going to find the changes happening. It's right coronary artery. We talked about some of these Dysrhythmias as far as blocks. And we also need to keep in mind that that right coronary artery feeds the right ventricle. And listen up, guys. Important concept. The treatment of a right ventricular MI is totally different than the treatment for left ventricular MI. Left ventricular MI, we don't want to put a lot of fluid. We fluid overload them. On the right side, we actually do purposefully administer excess fluids. Yeah, a right ventricular MI. And to really diagnose it, you need to do a right-sided ECG.
Okay, right ventricular MI,
We treat with a lot of fluids. We fluid load them.
but a left ventricular.
You got to be careful because remember a cardiogenic shock? You want to get their preload up to stretch the fiber as much as you can, recognizing that you can push them into heart failure.
But with the left ventricular, you try to get that,
You
get them.
you
fluids
get
up.
them there, you get them to a point, but not push it further. Okay, so that's an inferior wall MI, and you can see the changes here. Lead 2, lead 3, and the AVF are pretty accurate. And again, what I won't do for you is to throw them together, because that's a little bit too confusing. Septal, we're looking at V1 and V2. The septum, remember, contains a bundle of His, so again, you might have some conduction issues that are there. This is fed by the left anterior descending, and the R wave is very, very small in V1 and V2. If you remember back from that progression, you don't see it very, very well. So it's the septum between the two ventricles. I have seen such situations where the septum became so infarcted that it actually eroded, and you ended up with a ventricular septal defect. Not a good thing. So here's V1 and V2. You can see specifically in V2, you start seeing that ST elevation. V3 progressing to V4, it's back to normal. So again, it's looking at the septum, the middle. And a little bit of artifact there too. And then last but not least, the anterior wall, front of the heart, which is V3, V4. This is the one that is fed by the left anterior descending. This is also the one that feeds the bulk of the muscle mass of the left ventricle. So if I have an anterior wall that is damaged, you can't generate blood pressure. And these are the folks that go into cardiogenic shock. Okay, these are the folks that also have bundle branches we'll talk about in a sec. And these are occlusions. Depending upon how high it is how much muscle mass you end up losing. Actually, if the occlusion is here, above the bifurcation of the circumflex and the anterior descending, that's what's called the widowmaker. Drop dead. Drop dead Fred. So looking here, you can see V2's got some elevation, V3's got significant elevation, V4's got elevation, V5 is coming back down again. So you're looking at that anterior surface. Here's another look. Take a look at V2 through V4 and notice the progression that happens over time. Here I have ST elevation, ST's come down, T waves flipped, Q waves developed. progression of your anterior wall MI. Okay. What's that?
That one on the right looks like,
Upside down.
you know,
Looks like an upside down, yeah, but it's not.
it's just a QA with no R wave.
Correct. Why? Because it's dead tissue.
That tissue's okay.
Think about what the Q wave means. As that impulse is moving in the direction that it's supposed to be, it comes across dead tissue. So it's got to go backwards. As it goes backwards, it becomes a negative deflection. And that's why that Q wave is there. And will always be there. Posterior, I'm not going to concern you with, but just recognize that it's something you don't see directly. You have to look for reciprocal changes in the anterior wall. So if I see V1, V2, V3, V4, that's septal and the anteroseptal portion, front part of the heart. If I see reciprocal changes there, it might be a posterior, and we would need to get those posterior leads looked at. And we would end up doing V7, 8, and 9. And I think I had those on a previous slide where you're basically going around here. They're mimicking 4, 5, and 6, but they're doing it on the posterior side. Can we?
Done that often, right?
Often enough. Yeah, if you get an inferior wall, because the inferior wall, that artery also feeds the posterior wall. It's often associated with it, so you'll get it. What's that?
Sometimes the EKG machines, even the newer ones, don't have those extra limb leads.
Right. Not limb leads, but precordial leads. So again, this is where we end up seeing with a right ventricular infarct. The right ventricle can't pump blood, so it backs up into the jugular system or jugular vein, your liver engorgement, et cetera, et cetera. So there's the posterior. Okay. So just as a summary, that you kind of might need to know the different areas of the heart involved. Huh? Sure. Sure. Is anything ever enough, Katie? No. So let's talk about the bundle branches. Here I have my two, after my AV node, my bundle of His, it then branches into two primary bundles, one covering the right side of the heart, the right bundle branch, one covering the left, and the left branches into a couple of fascicles, an anterior fascicle and a posterior fascicle, and you can even get breaking beyond that point. Okay? Those are exclamation points. Widened QRS complex. Anytime you have a QRS that's wider than 0.12, it's either a ventricular origin beat or it's a bundle branch block. Okay? A wide QRS complex either means you have a supraventricular beat that has a bundle branch, or it's a ventricular beat. The origin is from the ventricle. We'll talk more about that when we get there. So that blocked bundle is basically the last part to be depolarized. That's why it has rabbit ears. That's why it has an RS, R prime.
Oh, I see it now.
Okay. What I need to look at is V1. Or, in the coronary unit, they often would put patients on an MCL1. If you remember, I talked about this before. It's a modified chest lead where it's mimicking V1. Why? Because I can tell if it's a right bundle or a left bundle that's being blocked. And the way we're going to do this is we're going to look at V1 and we're going to think of how a blinker works. If I'm turning right, what do I do to my blinker? push down. If I'm turning left, what do? I pull up. So I look at the J point.
Some of you.
Well, for right now, we're doing it this way. The old way.
The old way, were you rolling down our windows like this?
Sometimes we do the sign.
All right. So here are the steps. There might be a question on the test related to this. First step, take a look at V1 or MCL1. Go to your J point and move backwards. Here's my J point. J point is defined as the end of the QRS complex before the beginning of the ST segment. Agreed? Move back into the QRS complex. Is the terminal portion positive or negative? Positive, negative. If it's a positive, it's a right bundle branch. If it's a negative, it's a left bundle branch. Turn it up, turn right, pull it down to turn left. Yeah, I guess it was depending on which side the steering wheel was on at one point in time when you learned to drive. They're all now on the left-hand side, aren't they? Yeah, they are. Okay.
I can't remember. Volkswagen might be on.
Yeah, I think they were. I had one car that was on the opposite side. There you go. There you go. All right, does that make sense? I can determine if it's a right or left bundle branch. Okay, which is it? Is it wider than 0.12? Kind of hard to see from that tracing, but it is. Can you see the rabbit ears? How would you describe that QRS complex? How would you describe it? RS, R prime. Agreed? Some ST depression, right? Okay, but what about the bundle branch? Which bundle is involved here? Why right? Good. So right bundle branch, when you go back into the QRS, is always going to have a R prime wave being there. So V1, look at my J point, move back. It's upright. Left bundle, move back, and it's down. In V1, yes.
Is one more serious than the other? Like,
Left bundle probably be more just because you have a bigger mass of muscle. Which is it?
They're going to be one. It is a left.
right.
Hey, move back, goes down.
Oh, I said that backwards.
J point,
Oh, that's
back, it's down.
Oh,
Back and down.
so that's just an elevated ST
Back
segment?
it up.
Yeah.
Oh, I thought that was like functional.
Back it up. Hey, blink a bit.
Can you have both?
Well, yeah, but I mean, like, I thought it was gonna be, so if it's gonna be an actual other R.
If you see an R prime, it would be up.
Would it be like not rounded at the top like that one is? Right, but like that was
Left.
curved, so it's not gonna be.
But that, I mean, that,
So only V1 we use,
Only we only look at V1, correct? And that's why they use MCL1 in the coronary units. How about this one?
right.
V1, J point, move in, it's pointed up.
So would that be an R prime S big R?
That'd be an RS R prime, where the second R is capital.
Okay, so it's smaller, small R, small S.
Small R, small S, big R, prime.
Which one is prime the bigger? Or the second one?
The second one. The second one is always going to be a prime.
Okay, so it can be smaller or bigger.
It can be, yep. Okay, let's talk about cardioversion and electrical therapy. There is a distinction between the two because the who's in control of the energy is different between them. Defibrillation is basically a strong electrical current used to try and convert the rhythm from something that is chaotic into something that allows a normal pacemaker to take over again. Hopefully. Two types of defibrillators that are out there. I doubt you're going to see monophasic as much. Monophasic just means it's a current moved from one paddle to the other paddle. So I had a current moving from this part here to this part here, and it moved through the chest. Newer ones, predominantly all you're going to end up seeing in my mind are biphasic. Meaning they're not only moving from one paddle to the other, they're moving from that other paddle back to the other paddle, moving in both directions. Because of that, I can get away with less energy being used. I don't have to have as high of amount of energy being pumped through it. I can get by with less. And that's what's present in most implantable defibrillators are biphasic. Once we recognize that we have a rhythm that is able to be converted through defibrillation, as soon as that defibrillator is ready to use, we should immediately defibrillate. The two primary rhythms that we're going to be doing this on is VFib and pulseless VTAC. They're both treated the same way, defibrillation at maximum energy. Which on the monophasic was 360 and the biphasic you started at 200. Although each manufacturer is a little bit different, so I'm not going to be picky on that one. Peds, usually it's not a cardiac issue. They're normally a respiratory arrest, not a cardiac arrest, but we do it based upon their body weight. First one is at 2 joules per kilogram, and it goes up to 4. We don't use paddles anymore, so it's kind of an academic issue. But if you were to be using those paddles, there's a certain amount of pressure you have to place on them. Now we just use electrodes. The large electrodes that we place on the chest, one below the right clavicle, the other one over the apex of the heart on the left side of the lateral chest. Both of them are adhesive. And those are typically not only just defibrillation pads, but they also can be used for transcutaneous pacing. There have been case reports of individuals who were bagging somebody, and instead of taking the bag off and holding it away from the environment, placed it on the patient, or placed it on the bed next to the patient, created an oxygen-enriched environment. And when they defibrillated and it arced, it caught fire. Well, actually, some nitro paste caught fire. And that would not be a good thing for an arrested patient, is to have them burning. Just saying. So one of the pads goes on the upper sternum below the clavicle. The other one goes on the left nipple, anterior axillary line. Remembering that we have to be warned that energy is going to be released, because if you have your hands on the patient or on the bed rail, the current is not only going to go through the patient, it's going to go through you. In defibrillation, there is not a synchronization, it's an asynchronized release, so that we are in control of when that energy releases. Once it's charged to the appropriate level, I push the buttons, it releases the energy. There's the position. You can see the idea being is that the current is moving through the heart muscle to try and reset the timer. Okay. In the old days, those paddles could actually just be placed onto the chest to be able to get a quick look to see what the rhythm was. Now, again, we just use the pads, so it's kind of an academic issue. You guys know about AEDs. I'm not going to go anything further with that, but again, an AED is it automatically is looking at the rhythm that it sees, and based upon the amplitude and the width, it determines if it's a rhythm which can be defibrillatable. So in a pulseless patient, when I hook up an AED, it's looking to see if it's a rhythm, i.e. VFib or VTAC, that it's going to be able to defibrillate. If it sees a normal sinus or a sinus tac, it's too narrow, it's not going to touch it. It's going to say no shock advised. 4 steps, power it on, attach the pads, analyze the rhythm, and if it's appropriate, shock the patient at that point in time. Pretty straightforward. Turn it on first. Big hint. If no shock advised, it's basically a situation we're going to classify as pulseless electrical activity or asystole, and we'll treat that in a different fashion another day. I think we talked about rescue breathing, and you guys know all that. Cardioversion's different. Cardioversion, you are not in charge of when the energy is released through to the patient. The box is. The defibrillator determines when the appropriate time to release that energy is, so the technique is slightly different. Many tachydysrhythmias are associated with, really any tachycardia that you have that is unstable. If I take Amy and I make Amy run up and down the stairs 12 times, she's going to be tachycardic, she's going to be short of breath, she's going to be diaphoretic, but I'm not going to cardiovert her. She's symptomatic, yeah, but she's not unstable. Unstable means things like loss of blood pressure, chest pain, severe presence of massive diaphoresis. In those cases, we're going to cardiovert them and try to convert that tachydysrhythmia into something much more regular. And we'll talk about atrial tach, atrial fib, atrial flutter, junctional supraventricular tachs, and even VTAC with a pulse. All of them can be treated with energy. In fact, a little saying that I always have is tachy and awake, drugs you must take, tachy and a nap, zap. So if you lost consciousness and you're unstable, you immediately go to electrical therapy through cardioversion. Otherwise, there's pharmacologic intervention. Where cardioversion works is it's looking for the R wave, so we're going to press the sync button to tell it to look for an R wave. And it looks at the ECG tracing for something that's a positive deflection that's very narrow, and it's going to go ahead and lock onto that. So we can use less energy because we're directing where that current's going specifically. We start off normally at somewhere around 50 to 100 joules. And we can go ahead and repeat it at higher doses as we go. If the patient's conscious at all, it's probably a nice idea to give them a little bit of anesthesia or sedation, a little bit of Versed. And it's, especially in an elective procedure, often we're called at a bedside to be there with a resuscitation bag if the patient goes into cardiac arrest. And there are implantable cardiac defibrillators that are there. And these are the reasons why we would end up putting them in patients who end up having recurrent VTAC, VFib episodes that are not responsive. Yeah.
Had a kid come in, he was in WPW. He was
Oh.
unstable, and
Wolf
nurse-
Parkinson White.
The nurse said she put it on
Sync.
Superman, and they didn't. They shocked the kid.
Oh.
and They shocked him again.
Got him out,
Got him
but
out,
but
just
that's
showing
a
how
risk
easy
that you
it
end up,
is to-
yeah. The key thing with cardioversion, and a lot of people don't think about it, instead of just pushing the button to release the energy, you have to push the button and hold the button in until the machine recognizes an R and releases the energy. But you'll see people just push the button, the thing's not working. You got to push and hold it until it clicks. And it'll let go as soon as it does, yeah. Precordial, Wolf Parkinson White, don't worry about it. I don't think we do this anymore, but it was kind of cool. You basically are able to generate some degree of current. In the cath lab, they'll also ask patients to cough. That cough, that intrathoracic pressure changes enough to sometimes convert a VFib back into an ordinary rhythm. I'm not going to worry anything about precordial thumps. Pacing, we pace really for that first choice, the bradycardia and heart blocks. In theory, you could pace for some tachycardias, especially a polymorphic ventricular tachycardia, better known as torsades. And asystole, you can draw a line through. We never pace for asystole. That's old. Delete that.
Will the MDRC think that you should pay?
You should never see pacing for asystole. That's been out for almost 10 years. So I think it's pretty well assured.
Looks like an angry scratch out.
Yeah. Here we have our implantable defibrillator. No, I'm sorry, pacemaker, where it's pacing into the through one of the large veins. Typically, what we end up using in the ER or the ICU is a transcutaneous pacer. We used to float in pacers through a transvenous process. Don't do that anymore, and you can actually have an AV either pacing the atrium, pacing the ventricle, or pacing both. We note a pacemaker by looking at a vertical line on the QRS complex, or the vertical line that precedes either the P wave or the QRS complex. If it's an atrial pacer, it's going to be the P wave. If it's ventricular, it's the QRS complex. And the QRS that results is not going to be a normal-looking QRS. It's going to be wide and distorted because it's not originating through the sinus node. So we look for that pacing spike, and you can actually palpate the beat. Everybody see how this is a ventricular pacer. After that vertical spike, I have my QRS complex happening. Okay. This is the pacing spike right here.
Oh.
Then the rhythm starts. And I have this huge ST elevation and T wave. No P wave.
Why is it?
QRS starts right at the end of that spike. As soon as that pacer rhythm, or as soon as that pacer puts out the electrical current, the ventricle then conducts.
So it's upside down.
Because it's a Q wave that's,
This is the pacing spike. This isn't a wave. It then is the QRS complex.
so that's a large Q wave then.
Well, it's probably a large S, to be honest with you.
But is it the lead that's making it upside down?
It could be, yeah. Well, it's always going to be upside down because it's starting in the ventricle and moving where? Moving up. Moving up to the rest of the heart. So because lead 2 would be looking down, it's moving up, it's going to be an inverted wave.
Do you have a picture with the R? So the R pacer?
Picture of a who?
Well, with the pacing the R. So,
No, it doesn't pace the R, it just...
I mean pacing the P wave.
Oh, no, I don't. Or do I? No. This is a loss of capture. It's one that's not working. I have a pacing spike with nothing happening. It's not capturing. It's not inducing the heart to create a beat.
It wasn't an S wave, right? In the other one?
It technically probably is an S wave. It's because it's negative. All right. How much longer do I got here? I know. I'm feeling the same thing.
It's very overwhelming. Is there like a dummy
A lot of
version?
Is there a dummy version?
Holy crap.
All right, let me go through just the sinus beats, just so we have a little bit of bearing as far as how to compare everything else to. So we're going to take a look at the rate, because if the rate's greater than 100, it's some kind of tachycardia. If it's less than 60, it's some kind of bradycardia. We're going to look at the rhythm and regularity. Some rhythms are very regular. Some rhythms are periodic. Some rhythms are chaotic. We look at the R to R for ventricular regularity, the P to P for atrial. We're then going to look at the P waves. Are they present? Are they absent? Are they upright? Are they inverted? Do they all look the same? Is there more than one for every QRS complex? Those are all going to be tips for other stuff. And then we look at our numbers, our PR interval between 0.12 and 0.2, our QRS duration less than 0.1, and then our QT interval. I'm not as concerned so much as the QT as I am the other two. Then we look at the ST segment, elevated, depressed. We look at the T wave. We identify where the pacemaker of the heart is. Who's starting this beat? Is it the sinus node? Is it the junction, the AV junction? Or is it somewhere in the Purkinje fibers? So let's talk about those ones that have to do with some dysrhythmias here. Automaticity means that it's firing, it's starting from someplace. Could be the SA node, could be someplace else in the atria, could be something at the AV junction, could be from the ventricles. So our sinus rhythms, the four that we're going to, well, actually the three we're going to talk about, the first three. Normal sinus, sinus brady, sinus tachy, and sinus dysrhythmia. Normal sinus is pretty straightforward. P wave, one P wave for every QRS complex. P to P is regular, R to R is regular. Normal PR interval, normal QRS complex. Everything's normal. Let's go to the bar, right? So it's a sinus orientation. It's starting from the sinus, from the sinoatrial node, and it's progressing normally. So these are all examples of normal sinus rhythm. What do you notice about this one? It's got an ST segment elevation. Does that make it not normal sinus? No, it's still a normal sinus. It just that it happens to have an ST elevation. Or in the second one, an ST depression. Okay. Sinus Brady, normal P to P, normal R to R, upright P wave, one before every complex. The only thing here is that the rate's less than 60. Sinus bradycardia, you need to figure out, is this something that is symptomatic? If it's symptomatic, if the patient's blood pressure is low, if they're confused, if they're having syncopal episodes, then we need to treat it. Okay? And we treat it by the use of atropine. 0.5 to 1 milligram up to a max of 0.04 milligrams per kilogram, roughly 3 milligrams. And again, here are some things that I would call symptomatic. And I would be very comfortable in a test question giving you a scenario where you have a patient whose heart rate is 35, their blood pressure is 60 palpable, they're confused, they're diaphoretic. What's our first line of therapy? Atropine, 0.5 milligram. Alternatively, if you've reached the max of the atropine or it's significant enough, I can look at transcutaneous pacing, or I can use it using some kind of a vasopressor to be able to raise the blood pressure. Two popular ones are epinephrine as a drip, dopamine as a drip, not epinephrine as a bolus. I'm not going to give an amp of epi. That's wrong. Okay? Sinus bradycardia. Got it? Now, sometimes the rate is not quite below 60, but the blood pressure is low. There is an argument that we should probably begin therapy at that point simply because the patient is deteriorating. Unless there's some reason not to speed it up, speed it up. Sinus tack, again, normal looking P wave, normal looking P to P, normal R to R, PR interval is regular, QRS is regular, no problems there. The only problem is that the rate's greater than 100. And quite often less than 180, quite often less than 150, to be honest with you. And really they need to just figure out what the cause is, hypoxemia, anxiety, fever, and treat the underlying cause. So there's a sinus tachy. You can see that you get to the point where the P wave and the T wave almost climb onto each other. Okay, because it's getting so fast. If you truly lose a P wave, then it's probably an atrial tach. It's good if it's even faster than that. And I'll show you that when we get to that. Yeah.
I think at least a lot of physicians, because I asked this question, a lot of tachycardias, it becomes so fast, you start seeing the ST depressions because it's beating so fast.
Right.
It's not got,
Right.
Doesn't have good oxygenation going.
Right. Right.
So don't worry about it.
But it is something we need to address. Other ones that are there, I'm not going to test you on, but sinus arrhythmia is where as the person breathes, their R to R varies. You'll see it a lot in kids. Sinoatrial block, where basically the P wave just goes to sleep for a beat. Comes back the next beat. And then sinus arrest, where it entirely doesn't work. Their sinus node doesn't fire. And in that case, you really should see the secondary escape rhythms, junctional or ventricular, kicking in the process. So here's sinus arrhythmia. You can see that as you're breathing, you're having a variation in the P to P, or the R to R and P to P. This is where your calipers would come in best. Sinus block, again, if you use your calipers, you measure your R to R, measure your R to R. Hey, there should have been a P wave here. Sinus node just fell asleep, but kicked back on and right on sync. That's how you can tell that it was a block sinus beat, is that the R to R eventually came back to the same rhythm. There's another sinus arrest, where it's a little bit different. It's now, in this case, it's not timed. The sinus node just not only didn't stop for a beat, it stopped completely. And it eventually kicked back on again. But it's a scary time. That goes with a little movie at the beginning.